Hello everyone. In this presentation, we'll talk about right ventricular dysfunction in ARDS patients, recognition and management. And we'll start with this meta-analysis that included total of 9 studies with 1861 patients looking at mortality in ARDS patients in relation to whether right ventricular dysfunction was present or not. In the group with right ventricular dysfunction, mortality rate was 41% compared to a mortality rate of 34% if the RV was not dysfunctional. The odds ratio of mortality was 1.45, meaning that those patients with RV dysfunction had 45% increase in mortality compared to patients with ARDS but no RV dysfunction. With this, the outline of our talk will be definition of RV dysfunction, then pathophysiology, and then different diagnostic tools before we end up with principles of management. If you take a look on this echocardiography, you can easily recognize that the RV is dilated and the function is decreased. In general, RV dysfunction is defined as the inability of the right ventricle to sustain adequate cardiac output at normal filling pressure. However, certain criteria should be present to guide us in more objective definition of RV failure. And this would be based on number one, RV enlargement and right atrial enlargement. You can relate the RV to LV and get a ratio. If that ratio is more than 0.6, it indicates RV dysfunction. If the pressure is increased enough, it can flatten the septum, and this would be seen in both systole and diastole, as opposed to flattening of the septum in diastole only in cases of fluid overload or volume overload. The function of the RV can be estimated based on the tricuspid annular plane systolic exclusion, or TAPSE. If this is less than 1.7 centimeter, it indicates decreased function, and this can be done easily with the M mode, putting the cursor at the tricuspid annulus. Similarly, we can look at the tissue Doppler of the tricuspid annulus. In systole here, the S prime, if the speed of the movement of the annulus is less than 10 centimeter per second, it indicates that this is dysfunctional. In terms of pathophysiology, let's start with hypoxemia. Those patients with ARDS may have hypoxemia that will lead to vasoconstriction. At the same time, we may have imbalance in vasoactive mediators that will lead to more vasoconstriction as opposed to vasodilation. Number two, with increased PEEP and increased driving pressure, this will lead to increase in transpulmonary pressure that will compress on the intra-alveolar vessels and will increase the pressure on the right side. And the third component would be in situ thrombosis that may be formed during the ARDS process with the inflammation. So with the vasoconstriction, with the mechanical compression on the vessels and the thrombosis, the afterload on the right ventricle will increase. That will increase the pressure in the right ventricle. At the same time, with ARDS, we have dead space ventilation, impaired VQ matching, and lung edema that will lead to hypercapnia. There are some benefits of hypercapnia, but it may have disadvantages such as an increase in pulmonary vascular tone and depression of myocardial contractility that will lead to increased pressure on the right side and decreased function. At the same time, the stroke volume from the right ventricle is going to be decreased. That will lead to reduced LV preload, and also the increased pressure on the right side here will lead to bowing of the septum and decreased in the LV function. The increased pressure on the right side here will lead to venous congestion, and that will impair organ perfusion. This will show you that with increased pressure in the pulmonary artery, that is the stress that is put on the RV, there will be also strain on the RV, and the contractility will be impaired. Stroke volume is going to be decreased, and also the end diastolic volume is going to be increased. That will lead also to increased tricuspid regurgitation, and that will lead to decreased output from the right ventricle or decreased ejection fraction. And at the same time, as we discussed before, there's going to be septal bowing, and that will impact on the left ventricular function at the same time. This is the BV curve of failing right ventricle compared to normal ventricle. You can notice here the increased end diastolic volume. At the same time, this is the arterial elastance of the pulmonary artery. You can see it is increased because of increased pressure. With the increased arterial elastance, contractility is going to be decreased, and stroke volume is going to be decreased. This loop is what you see in patients with RV failure compared to normal PV loop. Arterial elastance is increased, and diastolic volume is increased, contractility is decreased, stroke volume is decreased. In terms of diagnosis, you can look at central venous pressure. That is most likely going to be elevated, but it is not a good indicator for the pressure or the volume status of the patient on the right side. However, a rapid increase in CVB following fluid challenge could serve as an indicator of impending RV dysfunction or failure. In patients with RV dysfunction, you may see pulse pressure variation, and it would be difficult to differentiate between hypovolemia and RV dysfunction. However, persistence of pulse pressure variation following fluid challenge indicates possibility of RV dysfunction. And the gold standard is pulmonary artery catheterization. That is going to show elevated CVB more than 20 millimeter, and CVB will be higher than pulmonary capillary wedge pressure. Cardiac index is decreased, less than 2. Mixed venous oxygen saturation is less than 55%, and of course, elevated pulmonary vascular resistance. Of note, there was no mortality benefit from routine use of pulmonary artery catheters in patients with acute heart failure. The most commonly used test is echocardiography, and transesophageal echocardiography is superior to transthoracic echo. However, transthoracic echo is more readily available, and you can do it at the bedside too. In patients with RV dysfunction, you can notice RV dilation at the base with a diameter of more than 42 millimeter. As we mentioned, you can relate the RV to LV, and the ratio, if it is more than 0.6, this is moderate dysfunction. If it is more than 1, it is severely dysfunctional. In addition, you can look at the RV area, and a fractional change of less than 35% indicates RV dysfunction. As we mentioned, TAPSE less than 17, and also you can look at the global longitudinal RV strain, which is an indicator of the diastolic and systolic function of the RV. If that strain is more than minus 15%, meaning that it is closer to 0, 10% or 5%, it would indicate RV dysfunction. In addition to TAPSE and the RV strain and the RV fractional area change, you can do myocardial performance index, which is the relationship between the isometric contraction time in addition to the isometric relaxation time divided by the ejection time, and if that ratio is less than 50%, it will indicate that the RV is dysfunctional. If it happens that CT scan is done for any other reason, you can easily notice the dilation of the RV and the RV to LV ratio. CT scan is not routinely obtained for RV failure. Similarly, cardiac MRI is not routinely obtained. It is not widely available and there is no good data. However, if it is done for whatever reason, it would show dilation of the RV and same RV to LV increase in the ratio. In terms of biomarkers, limited data on BMP, however, elevated troponin level in those patients with RV dysfunction and ARDS may indicate higher risk of death. The management would not be any different than the management of heart failure, concentrating on optimization of preload, increasing the contractility, and reducing the afterload or doing ECMO. In terms of preload, those patients with hypovolemia, they needed to be optimized in terms of the filling of the right ventricle, so contractility is going to be improved based on the Frank-Starling curve. It is preferred that we do mini fluid challenges in those patients with 100 ml of fluid over 1 minute and measure the improvement in the output on the right side. On the other hand, if you have a patient with elevated filling pressures, those patients need to be diuresed, and in some conditions you may do CRRT and hemofiltration. The second principle would be increasing RV contractility, and the first thing that you would do, you need to maintain atrial contraction, as it contributes to around 40% of the output on or the stroke volume on the right side. You need to maintain those patients in sinus rhythm. If the patient is in atrial fibrillation, you may consider chemical or electrical cardioversion. Similarly, you need to optimize the filling time by optimizing heart rate to improve the time for filling the right ventricle and improving stroke volume. If a patient has a heart block, you may consider putting pacemaker for those patients. Vasopressors would be needed for blood pressure improvement, and the preferred vasopressor would be norepinephrine, as it will increase systemic vascular resistance and reduce pulmonary artery pressure, but this is only at lower dosages. If you have to go up on the norepinephrine, at that time the pulmonary artery pressure may be elevated. Phenylephrine has more effect on increasing the pulmonary artery or pulmonary vascular resistance. Therefore, we would like to avoid using phenylephrine in those cases. Vasopressin is preferred as it has a minimal effect on the pulmonary vascular resistance, and it would have mainly effect on the systemic vascular resistance. The fourth component of this principle would be to use an inotropic agent with vasodilatation, mainly dobutamine or myrrinone. And we prefer using myrrinone in these cases, and you may combine the myrrinone with vasopressin to counteract the effect of myrrinone or dobutamine on the blood pressure. Limited studies on levosimendan, and it is only available in Europe. The third principle in management is reducing RV afterload, and that would be by reversing and controlling the precipitating factors, improvement of hypoxemia. Number one, as we mentioned, hypercapnia may contribute to the decreased contractility and increased pulmonary vascular resistance. Therefore, aiming for normocapnia would be a goal in these patients. Of course, this may actually not be possible, especially in patients with ARDS, that we have to do permissive hypercapnia. At the same time, correction of acidemia and hypothermia would improve the or would control these precipitating factors for increasing pulmonary vascular resistance. Use of pulmonary vasodilators, specifically inhaled nitric oxide for short term. As you know, nitric oxide is associated with acute kidney injury, and we rarely use it in the intensive care unit. You may use inhaled prostanoids such as epoprostenol, and limited role for oral sildenafil, but can be used also in those patients. Most importantly, you need to make sure that you have right ventricle protective mechanical ventilation, limiting the plateau pressure less than 27 centimeter of water and the driving pressure less than 14 centimeter of water. Prone position may unload the right ventricle, but you need to measure the improvement, as some patients may not actually improve, and the RV may be worsened with proning. So in selected patients, you may continue doing prone position in those patients if they benefit. Finally, extracorporeal life support. VV ECMO is effective to correct hypoxemia and hypercapnia and facilitate low pressure ventilatory approach in these patients. VA ECMO is needed in patients with circulatory support with RV dysfunction and cardiogenic shock that is refractory to vasoactive drugs. VA ECMO provides respiratory and cardiovascular support as deoxygenated blood bypass both failing right ventricle and the lungs. Therefore, we enhance unloading the right ventricle. This will show you the different modalities that we do in terms of management of RV dysfunction in relation to our interventions for ARDS. Let's start from lung protective ventilation. The blue rectangles are the interventions that we do in ARDS patients, and the green is what we're going to have in patients with RV dysfunction. So we do lung protective ventilation that will benefit our patients with RV dysfunction. However, we need to make sure that the plateau pressure is less than 27 and avoid intrinsic PEEP and limit the PEEP. PEEP titration is probably the best method to make sure that the PEEP is beneficial and it's not causing hemodynamic instability. At the same time, as we said, we need to limit severe hypercapnia. In terms of conservative fluid management, this is what we aim in patients with ARDS. However, we may have to do many fluid challenges in patients with hypovolemia and RV dysfunction, or test for volume overload and institute diuretic therapy or CRRT in patients with RV dysfunction. Neuromuscular blockade is used in selected cases in ARDS, but has no role in management of RV dysfunction. As we mentioned, inhaled nitric oxide is not routinely used anymore in ARDS patients, but it has an effect in those patients with RV dysfunction, as it dilates the pulmonary vasculature and decreases the pulmonary vascular resistance. Similarly, inhaled prostacyclins such as epoprostenol can dilate the pulmonary vasculature and improve the afterload for those patients. Norepinephrine, epinephrine, vasopressin, and Mirinon are the preferred agents in terms of hemodynamic supports. Prone positioning is beneficial in selected patients who can respond to changes in gravity for ARDS. Similarly, it may have an effect in patients with RV dysfunction to unload the pressure on the right ventricle. With this, we come to the conclusion that we defined RV dysfunction as the inability of the right ventricle to sustain adequate cardiac output at normal filling pressures. We understand the pathophysiology as it is mainly vasoconstriction, positive pressure ventilation, in situ thrombosis that will lead to increased RV afterload, and that will lead to RV dilation and dysfunction. This will lead to LV preload decrease in LV preload and dysfunction, and then venous congestion and impaired organ perfusion. In terms of the diagnosis, we rely on the presence of RV dilation with RV basal diameter more than 42 millimeter, RV to LV ratio more than 0.6, right ventricle fractional area change less than 35%, TAPSE less than 17 millimeter, and global longitudinal RV strain more than minus 15%. In terms of management, the principles would be to optimize RV preload, increase RV contractility, reduce RV afterload, and use of ECMO in certain situations. Thank you very much.